And again, welcome everybody. Welcome to the Robert Wood Johnson Foundation's Systems for Action Research Program and our regular Research in Progress webinar series. We've got an excellent lineup of research in progress for you to hear from today. For those of you who may be new to this webinar series and to the Systems for Action Research Program, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. We've been operating for about 4 years now, and we support studies that test innovative ways of aligning medical, social, and public health delivery and financing systems with the goal of, by aligning those typically fragmented systems, we're moving to improve population health and make progress in achieving health equity. The research you're going to hear from today is really interesting study looking at ways of better connecting the education and health systems to better serve vulnerable population groups. We'll be hearing from a team based in Los Angeles that includes investigators from UCLA, both in medicine and public health, working with the Los Angeles Unified School District on testing an innovative mechanism for aligning, again, education and health systems through, in part, through data exchange and data integration. I am confident you're going to be want to hear the findings and lessons learned from this study today. So let me introduce our speakers for today. First of all, I should introduce myself. I'm Glenn Mays. I am a director of the National Program Office and the National Coordinating Center for the Systems for Action Research Program. I'm also a professor of health systems management and policy in the Colorado School of Public Health here at the University of Colorado. For those who may follow our work, I've recently moved here to this position in Colorado after a long time at the University of Kentucky School of Public Health. So you may notice a little bit of a change in my affiliation. Our presenters today from the Los Angeles research team include Dr. Rebecca Dudovitz, who is an associate professor and associate chief of research in general pediatrics in the Department of Pediatrics at the David Geffen School of Medicine at UCLA. She's also associate program director of the National Clinician Scholars Program there at UCLA. And is actively involved in the health services research programs there. She graduated from the Geffen School of Medicine at UCLA and also did her residency training in pediatrics there at UCLA, and then completed an RWJF Clinical Scholars Program fellowship, as well as receiving a master's degree from the Fielding School of Public Health there at UCLA. And she's a real leader in studies of how schools impact health and how to better align educational systems with health systems. We'll also hear from another member of the research team, Eryn Piper-Block, who's a rising fourth-year PhD student in health policy and management in UCLA's Fielding School of Public Health. And her research also focuses on education, the intersection of education and health policies and their effects on child well-being. Also joining us for today's webinar, a third member and leader of this research team is Dr. Cheryl Kataoka. I apologize for my mispronunciation of your last name. And she's a professor in the UCLA Division of Child and Adolescent Psychiatry, serves as training director of the Child and Adolescent Psychiatry Fellowship Program there. A long history of collaborating with schools and school districts in Los Angeles and as well as around the country, and again, studies of how schools and the school environment affect health and studies of how to better integrate schools and health systems. We've got a great set of speakers from the Los Angeles research team to share with us what they're learning about their research project. So with that, I am going to turn it over to our first speaker, Dr. Dudovitz.
Hi, thank you. I'm just going to try to advance the slides here to get to the first part of the presentation. Let's see. There we go. All right, so I just want to mention that, thank you for that great introduction of our team at UCLA. I just want to mention that we're also here representing our partners in the LA Unified School District this is a truly partnered project, and so I want to acknowledge their contributions as well. Pia Escudero is the Director of Health and Human Services at LAUSD. Mary Jane Puffer is the Executive Director of the LA Trust for Children's Health, and Joshua Kaufman represents school mental health. All three of these folks we've worked with for a long time, and they've really helped us direct this analysis. So we'll start out by just giving you a background on the relationship between behavioral health and academic outcomes, and really give you a sense of where this project came from. And then we'll go through a couple of the analyses that we've completed to develop a risk indicator tool with the goal of identifying students who are at high risk for behavioral health outcomes. We first developed and validated the tool using a national data set, the National Longitudinal Study of Adolescent to Adult Health. And in our second step, we tried to apply this tool to a local data set from LAUSD focused on PTSD, or post-traumatic stress. And then we'll wrap up talking about kind of how we think about these findings and what we feel like the next steps are for us. So this project is really grounded in a wealth of research and data showing a robust and consistent relationship between school performance and behavioral health outcomes, which we generally define as mental health and substance use. I'm going to start by just giving you a snapshot of the literature in this area. So first, academic performance has been consistently linked to substance use. And this association is incredibly robust across time, region, demographics, and has also been shown with a whole variety of school performance measures. So some examples of school performance measures that are linked to these outcomes are grades, standardized test scores, high school graduation rates, grade retention, and educational attainment. And what you see pictured here is just one example from a study that we published with Mitch Wong on a sample of about 1,000 low-income minority students in Los Angeles. And you can see here that students who earned at least a B- or above in terms of their grade point average had lower rates of all 5 forms of substance use compared to students who earned a C+ or lower. And you can also see, if you look across these different models, the model here on the far right controls for demographics, school characteristics, and parenting style. So you can see that the relationship is incredibly robust. In this same analysis, we also did a similar analysis using test scores as opposed to grade point averages, and we found similar results as well. And although in the previous slide I showed you an example using dichotomous measures, when we use continuous measures of school performance, you generally see this dose response that's pictured here. So this data is from the CDC's Youth Risk Behavior Survey from 2009 and shows how rates of substance use and other unhealthy behaviors increase as grades decline. So ultimately, it's clear from all of this literature that school performance is highly correlated with behavioral health issues. There's evidence for causality in both directions, with both poor school performance likely contributing to behavioral health problems and behavioral health problems contributing to poor school performance. And in addition, there's a whole host of factors that have been identified that impact both school performance and behavioral health. However, the beauty is that regardless of, the causal relationship here, or even the direction of the association, as long as school performance and behavioral health needs track together, this suggests that we might actually use academic data to help us identify students who have behavioral health needs, with the ultimate goal of getting them into services. So from a population health management standpoint, we feel like this strategy has a number of advantages. First of all, it capitalizes on a wealth of academic data that's already collected on nearly every child. So that means it doesn't rely on families having to come into contact with the healthcare system to be screened for behavioral health problems, or attending a school that has the resources to do universal screening, which would be wonderful, but is often prohibitive. And that's really important because these other systems and ways that folks come into contact with healthcare, we know that there are barriers for folks seeking behavioral health services, and these barriers disproportionately affect disadvantaged communities. So we feel like the system might also address some of these disparities in access and utilization of mental health services. And then finally, our ultimate goal is really to identify kids early on who have a behavioral health need and intervene before those issues cause further academic and health deterioration. So that leaves us with a challenge. I've already told you that there are a whole host of different ways to measure academic performance, and that many of them are associated with behavioral health. So the problem is we don't know which ones are most meaningful and most sensitive and specific. And the other issue is that we don't want a tool that just flags every low-income minority student as being a student at high risk, because we want this tool to be feasible and useful in diverse communities and in those school systems that are most stressed. So to address these challenges, we really sought to develop a risk indicator tool to predict the risk for a variety of behavioral health outcomes using AdHealth, which is a national data set that I referred to before. And I will turn this over to Eryn to kind of walk you through our methods and how we approached this challenge.
Great. Okay, so we used a series of logistic regressions and created models that were different for all of our outcomes. So for each outcome, depression, and then several types of substance use, and then comorbidity, we built models that had interactions that were, we chose the ones that were significant and ran these models in a split sample. So the split sample was randomly selected, and we also use survey weights because that's a necessary structure within AdHealth. Let's see if I do not have the controls yet for to advance the slides. Rebecca, do you want to just advance one slide for me? Thank you. Okay, so we did a few things in order to test the model. So once we created a base model for each outcome, we used both a pseudo R-square and the test function within Stata in order to select which interactions were significant. Interactions that could include something between gender, free or reduced lunch, race, and ethnicity. So some combination of those variables. And then we also looked at potentially squared terms, such as grade point average could be a squared term and was in a few of our models. Then once we had our, once we built the model within the subsample number 1, then we validated by using the same model and running our test statistics in this second sample. So this is a pretty standard procedure for creating some type of risk assessment tool. So we used the area under the curve statistic, the ROC curve, and the Breyer score and calibration score for these purposes. And then we'll show you our descriptive statistics next. Okay, so like we said, we used AdHealth. So this is a nationally representative school-based sample. We used both Wave 1 and Wave 2 data, and our sample ended up being around 6,500 students after dealing with missing data between the 2 waves. The high school transcripts were for about 10,000 students, but we were then able to use about 6,500. So this, besides this high school transcripts, everything else was self-report. So the free or reduced lunch status, actually, that one was also from the transcripts, but the substance use and the attendance were also self-report in this data set. So we had participants between grades 9 and 12, and we only included those that had a valid survey weight and data on at least one outcome, and they obviously had to have the academic transcript. Oh, did I lose the... oh, here we go. Okay, so this is our descriptive data. This is the weighted sample. And so as you can see, it's predominantly a white population, 71%. So this is quite different from our other samples. So we also broke out race and ethnicity separately. So we have primary race, and then 10% were Latino, Hispanic ethnicity. We had about a quarter of our students having missing data for free or reduced lunch status, so that's something to note. And about half of the students in the sample were 12th graders. So, and you can see here our some of the outcomes that we have. So about 36% of the students in the sample had some type of risky substance use, and about 16% were considered depressed, and about 44% had some type of risk, so either substance use or depression or both. And there were about 7% that were comorbid, so both substance use and depression. So this is the results from our models. So the LROC is this area under the curve statistic, and so the higher the statistic, the better. So the reduced model is with just the demographic characteristics, so not the academic characteristics. We wanted to see, as Rebecca mentioned, we wanted to create a model that would go above and beyond indicating that, for instance, low-income minority students would most likely have higher rates of these outcomes. So we wanted to see that the reduced models would be have smaller LROC scores than the full model. So that is true for all of our outcomes, but especially notable for other drug frequency use, and marijuana use. So that's mostly what's notable here. And let's see, is that the... Okay, so our conclusions from this first validation of the prediction tool is that there is, it is promising for us to consider this prediction tool strategy for academic data to find risk for behavioral health conditions. However, the data that we had from AdHealth is not especially precise because a lot of the data is self-report and it's only collected once a year. So we are interested in refining our model using actual academic administrative data from schools so that we can have a better sense of especially the attendance data, since self-report attendance data may not be as precise or useful as the data that the school collects on a regular basis. And so these are just some of the limitations that I mentioned, and we're hoping that that will be possible with other data sets. So I'm now going to turn it over to Cheryl Kataoka, who will explain our second step in the process.
Great, thank you so much, Eryn. So with these findings from the large national data set AdHealth, we were really interested in working with our school-based partners to understand how to bring this into the real world and use this methodology to help our district really be able to identify those kids at most risk for behavioral health problems and be able to use their limited resources more efficiently. I'm looking for the controls. If someone has the controls, if they could just advance to the next slide. This is just a description of our pretty massive Los Angeles Unified School District. It's the second largest district in the country, 694,000 students, K through 12, and the vast majority living in poverty, 82%. We also have many, many languages spoken in the homes of our students, with 21% being English language learners at school. And just for perspective also, about 7,000 of our students are living in foster care. So even though Los Angeles Unified is one of many districts in Los Angeles County, it is by far the largest. And it has the vast majority of students are at risk for behavioral health problems. Next slide. And this just also describes the ethnic racial breakdown with most of our students being Latino, 74%, 8% African American, 6% Asian, and the remaining Caucasian. Next slide. And then in terms of academic achievement, this is an area that our district is continuing to press into and working to improve. But at the moment, it's pretty startling that the proficiency for our 3rd through 8th graders and our 11th graders are quite low, with proficiency in math being at 33%, English 43%, meeting the attendance standard at 73%. And this is measured by having at least 96% or better attendance. And then our graduation rate overall for the district is 75%. And then our district also has been measuring school climate across all schools in our district. So this is a breakdown of a sample of that population for elementary, middle, and high school. And although in elementary school, students feel relatively safe, middle and high school are more at the 50 to 60% range. So really a lot of work to be done there as well. And our schools are, continuing to work with their school resource officers to be less punitive and really trying to build more community across our different schools. But I think, it's challenging. Certainly, the vast majority of our schools are in low resource neighborhoods and areas where there's a lot of crime surrounding the schools. So I think safety is really, first and foremost on our district's mind, as well as, really one of their main priorities. Next slide. And along with this, there was data that we collected with the district that looked at risk for post-traumatic stress, measured by the primary care PTSD symptom list, which is a 4-item brief screen. Really just not to diagnose, but really just to understand risk. And the district looked at kind of those at highest risk and found that almost 26% were at what would be considered high risk for post-traumatic stress, but another 22% at this moderate level, just below kind of the cutoff point. And so they are really, kind of focused on this group of students, 48%, who are at moderate to high risk for post-traumatic stress. And it's really been the level of trauma and cases that these students are exposed to are of great concern, because our district is well aware that many of these traumatic experiences that students have are greatly related to the way that they're able to perform in the classroom and learn. And so they are really working with their school mental health folks to try and improve the coping strategies of these students, really working with kind of whole school climate and culture to help students feel more safe. So, until those things are done, certainly it's much more difficult to learn and to excel in school. Next slide. And so, this is really kind of the traditional multi-tiered system of support that schools often use. And at the top of the triangle is Tier 3, which for many, many years, our district and others across the country have really focused their efforts, really putting out the fires, doing the most intensive treatments, doing crisis intervention, responding to suicide attempts. That this is where the vast majority of resources have been put in various schools. Next slide. This slide was created recently by my collaborator at Los Angeles Unified, Carla Lavelle, and she she and others in our school mental health group have really worked to bring more universal services to students, providing classroom curriculums that provide students with kind of resilient skills and teaching teachers about the effects of trauma on students, so that they are more aware, that they are also more aware of those students that might need referral to specialized services. And then targeted and intensive services also being provided, but to a lesser degree, if in fact they're doing more universal. And then finally, crisis response at the tip of the triangle, but really at, kind of when all else fails. So as part of this universal kind of approach, the district has really been interested in, we've been working very closely with them in trying to understand how to harness all the data that they are collecting now, electronically, and have across all their schools and for all their students. How can that data be used to identify those students that may be in need of, say, a targeted intervention or an intensive intervention? What schools perhaps need more resources because they have higher risk for needing behavioral health services. Next. And so this also is just another diagram from Carla, who this is really kind of the frame of their services, where it's, the student encapsulated in family services, also embedded in classroom services, and then whole school approaches to bring about that kind of whole arc of prevention services in schools. Next slide. This is also from another study that we conducted with the district, in which about 28,000 sixth graders were screened and asked about their violence exposure in the past year. And 40% of these sixth graders reported having knife or gun violence exposure in the past year. And this excluded exposure to hearing about it, to seeing it on TV or in movies. This is really personally witnessing or being victim to this kind of violence. And that overall, our sixth graders reported, 73% reported some type of violence, whether it was weapon related, physical, being hit, attacked, kicked, punched, verbal violence, like threats to your life or well-being. So data like this that has really impressed the leadership of our district, that these kinds of problems are really important to address if we're going to decrease the gap in terms of graduation rates and some of the other academic indicators that I presented earlier. Next. So this was also from that same sample of 28,000 students in the district. And we looked at the violence exposure related to different school indicators, such as absenteeism. So this is from the cross-sectional survey, so one point in time. And what we found was that the highest odds of absenteeism was seen for boys who were both victim and perpetrators of weapon-related violence. And for girls, they were those who reported both being victim and perpetrators of verbal violence. So slightly different types of violence related to higher levels of absenteeism. And the next slide. And then similarly, we looked at violence exposure, different types of violence exposure. So weapons, physical violence, verbal violence, and then kind of a total amount of violence. And for this one, for suspensions, we found the highest odds of suspensions in both boys and girls were for any victim perpetrator violence. So didn't really split out by gender. So next slide. So then our next step was really to use the same modeling that Eryn described for the AdHealth data. We applied to data that we had available with Los Angeles Unified. This was kind of a convenient sample of students who had received the universal classroom curriculum, the resilience program I spoke of earlier. And we looked at a sample of 9th grade students who had a screening, the same post-traumatic stress scale, 4-question scale, and had data from the school district merged. So Eryn is going to walk us through what some of that data looked like.
Great. So as Sheryl mentioned, for our sample that was actually used for this analysis, there are 3,300 9th grade students. Let's see, I have control. So this is our sample description. So it's quite a different sample than AdHealth. So we have, in this specific sample, 86% Hispanic. It's also notable that we were not able to break out race ethnicity for this sample. It was just Hispanic Latino is just one of the different race ethnicity categories here. Then we have 72% of the students in poverty, and 7% are English language learners. Also, what's not on here, the sample description, is the amount of students that have PTSD, which is, or that would be considered at risk for PTSD, and that is 20%. Let's see. Sorry, I'm lost the. Here we go. Okay, oops, sorry. What is happening? Okay, I think I have controls now. Okay, so these are the results. So what we did was try to create models as similar as possible to what we had done for the other outcomes for AdHealth, and then run the same models here with PTSD. It's definitely something to note that we didn't have PTSD as an outcome in the AdHealth data set. So this is one of 2 data sets we wanted to validate the models in for LAUSD. The other one we're still waiting on. So this one only has PTSD as an outcome. So we did the same thing here where we had a logistic regression for yes or no if a student had PTSD, and we have a, or at risk for PTSD, we have a demographics only model, so our base model, and then we added academic variables. So this is the actual logistic regression output. So I'm not going to go over this too much, but just to note that we did see there is a, when we added the academic outcomes to the full model, those were a significant significant predictors as a whole for the at risk for PTSD. However, if sorry, I'm not sure why this keeps happening. No, I think it just, I don't know if I have the controls, but I think that the
we'll see if we can get the slides back. going here.
Okay, I'm so sorry. I don't know what happened.
It's all right. It's technology. A little unpredictable.
I'll just explain what was on the slide, and we can hopefully get it back up there. So the LROC scores that were at the bottom of that slide were much lower than what we saw, especially for the substance use outcomes for our ad health population. So I think it went from about 0.58 to 0.59. So that's not nearly as promising as what we saw for the ad health data, and we're not sure quite why that is. It's a preliminary analysis, but we're wondering whether it's because of the homogeneity of the sample, or whether PTSD is not as sensitive to academic and demographic data than, for instance, substance use. So that's something that we'll be able to look at using the third data set that we are that we will soon have to analyze, which has both PTSD as well as the substance abuse and depression outcomes.
Fantastic. Thank you so much, Eryn, as well as our other members of the Los Angeles research team. So we're working on getting our slides back up. But in the meantime, I want to encourage folks who are with us on the webinar to submit questions, as we are now going to be entering into the Q&A portion of today's webinar. And you should be able to see, if you're with us on the web portion of today's webinar, you should be able to look down at the bottom of your screen and see a Q&A icon. You can click on that and use that to submit your questions. So I know that we've already received a couple of questions, and first one for the team is a question about how depression is defined and identified. I think this question was directed at the part of your analysis that was using the national ad health data. But would members of the team want to tackle that question for us?
Yeah, I can explain. So it's using the CESD-10 variable, and so there's a specific cutoff for that that we used, and it's a self-report.
Fantastic. We've got another question, I think, asking just about the time frame of the data that was used. And again, I think this is referring to your analysis using the national ad health data.
I can address that.
Okay, yeah, go ahead.
So the ad health data was collected in the 1995 school year, and we used 2 years worth of academic data. So it is representative of students who were in high school in the 90s, which is another limitation of the data set, and part of the reason why it's so important that we repeat these analyses using current data.
Great, fantastic. And again, welcome folks to type in additional questions as we move along. And I'm seeing another question, which relates to how does the study identify students with highly functional depression, including those that could have high academic performance? Is there another way that could complement your tool? So thinking about, I guess, students who've got a behavioral health condition like depression, but that are highly functioning in terms of academic performance. And so you might have the potential to have a false negative in your prediction tool unless there's a way of addressing that. Great question. Any thoughts from our panelists on that one?
So I'm happy to address that. That is definitely a limitation. But part of the reason why we also think it's really important to look, why we looked at so many different combinations of academic variables, because an A student who, for example, becomes a B student, that might be a flag for that particular student that there's a behavioral health issue that's not being addressed, whereas a C student becoming a B student is not a flag. And so, you know, this issue of the fact that sort of there's probably not a universal academic cutoff for every student, and we probably need a combination of academic variables to really find out which students are struggling, is exactly why we did this project. I 100% agree that we probably need some additional academic variables to increase the sensitivity. Some of the things that we've considered is now that many schools are moving to electronic grade books, even things like homework completion rates and sort of early indicators of a drop in function that might not be so severe as to affect grades, are really what we're excited about moving to in the future.
And this is Cheryl Kataoka. I would also add that, you know, small changes in attendance can also be seen with more of our internalizing symptoms. Students that are experiencing anxiety or depression may or may not see drastic jumps in their like school functioning, but you may see that in attendance as well. So I think, again, I would agree with Rebecca that this combination of different indicators and kind of fine tuning it, looking at it more closely than kind of at the end of the year, once a year, but ongoing, is going to really be a powerful way to detect these students earlier.
Fantastic, fantastic. Thank you for that. I wonder if I want to ask another question, a little more global. I think this research that you've shared with us today is remarkable for a number of different dimensions. But I think one is fundamentally the partnership between your research team, your academic-based research team, and the school system is pretty remarkable, and obviously critical to the success of a project like this, where you're developing a tool and then wanting to test it in a real-world school setting, and hopefully then leading to actual interventions that can be adopted in that school setting. I wonder if you could describe for us a little bit about how this relationship has developed between your research team and the Los Angeles Unified School District, because I know schools can face a number of challenges in kind of finding the bandwidth and the time and the effort and the resources to participate actively in research initiatives like this. So I wonder if you could give us a little bit of background about how this relationship has developed and some of the strategies that have been successful in maintaining it for this research project.
Yeah, well, I can start us off. We all have had our relationships with the district, and for me, mine started about 20 years ago when I was a Robert Wood Johnson clinical scholar, and brand new to research, bright-eyed, wanting to go in the district and really focus on anxiety disorders, because I knew from my child psychiatry training that that was the most common disorder that we typically see in child psychiatry for children. But lo and behold, when I met with, at that time, it was Marlene Wong, who was the director of school mental health for the district, she said, hey, you know, that's all great and fine, but really I don't think our principals or teachers are, you know, going to want to give us, you know, time in the classroom or being able to pull kids out to focus on anxiety disorders, but what they really care about is trauma. And that is really the area that our district really is, you know, trying to grapple with, you know, and her psychiatric social workers day in and day out would be sitting with students and hearing about stories of, you know, homelessness, of violence in the street or at home or bullying in the schools, and that they were seeing that those experiences were really impacting how kids were then in the classroom, falling asleep during math class because they were up all night because their apartment was being raided. And so those kind of, that kind of refocused for me, my whole area of research and, you know, really partnering with schools, really understanding the, you know, what their mission was. And it wasn't to, you know, be a mental health clinic in the school. It was really to educate students, to help them learn. And so that has really shaped all the research that we have as a team been working on, really trying to work with the district, with the school mental health, psychiatric social workers to help students learn better and to address the issues that are most pressing to the schools that we work with. And so that has, you know, really been why for, you know, for my career, we've really focused on giving students the tools and teachers the tools and administrators the tools to deal with the vast array of trauma that our students are experiencing. And, you know, so, you know, just yesterday we were meeting with a large group of LA Unified administrators and their IT department, and they're getting ready to launch, or I guess they've already launched, this whole child dashboard where schools, teachers, principals are going to be able to easily access data that the district has been collecting on specific students, looking at their whole school, looking at classrooms, to better be able to identify kids that are at risk academically. And wouldn't it be great to then meld our social emotional learning data in that to really help teachers and principals detect when, you know, kids may be at risk. So this kind of, you know, analysis that we're learning from this project is really fueling kind of these next steps in, okay, we have this data, it's available now to, you know, schools and teachers. How can they best, you know, harness this great, you know, massive amount of big data they have to now understand, okay, when I see XYZ, you know, students missing 2 days or more in a row of school, or whatever the model ends up being, that's a kid that I need to, like, you know, talk to after class, or find out from their parent if there's a stressor at home, or, you know, maybe have the psychiatric social worker on our campus come talk to them and see if there's, you know, like a group that's going to run that will really address the issues they're dealing with. So that's such an exciting, like, we're just at the cusp right now, I feel like, and our partnership has come such a long ways and has been so fruitful. I think we've learned as researchers, and, you know, hopefully we've been able to give back to the district as well to help them use their data in the most efficient way possible.
Fantastic. Thank you, Dr. Kataoka. Those are excellent insight and examples of productive research and practice relationship there that you're working through with the school district. That also answered one of our other questions that came in about the value proposition for schools to that they face to motivate them to work on these kind of issues. I think you gave us some nice examples from how that's playing out in the Los Angeles district. I wanted to, I know we're just got a few minutes left. I wanted to ask, this is great work happening in a very large and diverse setting, but it is just one school district. So I wonder, do our panelists have any thoughts about the extent to which these findings and the applications that you're developing might, how well they might apply in other school settings around the U.S.?
I can address that. So that's one of the reasons why we started developing the tool in the AdHealth sample. Although the sample is from the 90s, so it's a little bit dated, it is nationally representative. And that's really one of the values of using that data set. Actually, if you recall from Eryn's presentation, the results in the AdHealth sample were more positive in demonstrating that academic data better predicts risk for behavioral health in that nationally representative sample. So if anything, I think our findings suggest that this might work better in more diverse nationally representative schools.
Fantastic. Well, this is very, very exciting work, the work that your team has been able to complete, and also the next steps and future directions that you described that are now playing out with your team and the school district. So I want to thank you all for all of our panelists for making time to share with us what they're learning from this research project, and certainly invite our participants in the webinar and attendees to stay tuned to our the Systems for Action research program for updates and other findings that will be that may be coming out of this research team and this project. So stay tuned to our website as well as our other webinars and events for more findings to flow from this and other projects. I do want to remind folks that this is a regularly occurring webinar. And we have we'll have another webinar, research in progress webinar toward the end of this month, July 31st, which you'll see on the slide showing now that we'll be hearing from our team that is working with the Cheyenne River Sioux tribe and looking at some ways, testing some ways of aligning health and social services for Native American populations using some community engaged decision-making alignment mechanisms. So another webinar that you won't want to miss. So again, thank you so much for tuning in to today's version of the Systems for Action Research in Progress webinar. We will be archiving a recording of this webinar as well as the slides that will be posted on the Systems for Action website very soon after today's webinar. So definitely stay tuned to our website at systemsforaction.org. And as always, our appreciation to the Robert Wood Johnson Foundation for their support of this webinar series and for the larger Systems for Action research program. Hope you have a productive rest of your day. Thanks so much for joining us. And again, we'll look forward to joining with you again at our next webinar on July 31st. Thanks so much. So long, everybody.